My name is Ginger Park. I'm from Seoul National University. So let me introduce the pattern of LV remodeling first. So if we have heart failure with preserved ejection fraction, we have this kind of a concentric remodeling. That means we have a similar diameter, but increased wall thickness. By contrast, half-rev patients have eccentric remodeling. They have a larger LV diameter, but relatively preserved LV wall thickness. We know that according to lower Laplace, the wall stress is directly proportional to the pressure and radius and indirectly proportional to the wall thickness. Therefore, half-PEV patient had mildly increased, whereas half-rev patient has severely increased wall stress. And we know that the NT-proBNP is a good surrogate for neurohumoral activation, and half-rev patients have twice as high BNP level than half-PEV patient. Here, the median was 2,700 in PEV and over 5,600 in half-rev patient. We also know that from the clinical trials that drugs that target neurohumoral activation, beginning with the ACE inhibitors to the sacubitril/valsartan, do work in half-rev. But these drugs do not work in patients with half-PEV, suggesting neurohumoral activation modulation is different among the heart failure phenotypes. For instance, for carvedilol, if they work in HREV but not in half-PEV, the same story is for the spironolactone here. There's a 40-year-old patient who came with dyspnea, had the NYH function class 2 heart failure dyspnea. But 1 month ago, there was an aggravation of dyspnea. This is the chest X-ray at the first medical contact. You see here's a cardiomegaly with interstitial pulmonary edema. ECG shows large QRS complex, suggesting he may have enlarged the heart. He was treated with the guideline-directed medical therapy, carvedilol, ivabradine, sacubitril/valsartan, furosemide. And after 6 months of the treatment, there's a decrease in heart size as well as decrease in QRS complex. And the echo shows at the baseline a large LV end-diameter diameter of 64 millimeter, ejection fraction of 23%. And after 6 months, the heart is smaller, ejection fraction is now 51%. The doctor may congratulate the patient that the heart function has recovered. And I'm very sure that some of you may heard this question from your patient that, thank you, doctor, can I stop taking heart failure pills? The question here is, does the patient have HREV or PEV? And how do you treat the patient like REV or PEV? Do the drugs work in patients who recover the ejection fraction to greater than 50%? And then can I stop the drug? The universal definition for heart failure had changed the MRF to mildly reduced. It also introduced a new term, that is the heart failure with improved EF. And the first question that I have is, what about continuation of the drug in this patient who improved the ejection fraction? We know that the survival of patients with a half-REV and half-PEV are very similar, as shown here. If you follow up the patient to perform a longitudinal perform echo and look at the longitudinal change of ejection fraction, you will know that some of the patients with the REV will improve the ejection fraction, who have the best prognosis, whereas some would have the persistence of REV who has worse prognosis. Because the proportion of these two phenotypes are similar, the combining survival curve will be somewhere in the middle of these two curves. Some of the patients with half-PEV will decrease the ejection fraction. I call them decline EF, who has the worst prognosis compared to those who have persistence PEV. Because it's only 10%, if you combine the two survival curves, they will meet around here. And that's the reason why we have very similar prognosis between the phenotypes. But in the longitudinal follow-up of the ejection fraction, we know that there are 4 distinctive heart failure phenotypes. Another interesting phenomenon is if they improve the ejection fraction, it does not matter whether they have ejection fraction less than 20% or greater than 30%, they will improve the ejection fraction to greater than 50%. And the similar story is true for the HFpEF patient, again suggesting that they are two distinct heart failure phenotypes. So we also made this study. Patients were diagnosed at index admission for acute heart failure, and they were diagnosed as a HFrEF. We performed an echo after 1 year, and they were reclassified as having improved EF or persistence PEF. And those with improved EF had a better prognosis. Interestingly, all the drugs, beta blockers, RAS inhibitors, seem to work in patients who have ejection fraction greater than 40%. And this is also true for beta blockers after adjustment for other clinical factors. And for patients with persistence PEF, that means patients who had decreased EF less than 40% at admission and after 1 year, this drug seems to work in this patient. I told you about the heart failure with declined EF. About 10% in our registry declined the ejection fraction during follow-up. So the same story among HFpEF patients, 10% have declined EF at 1 year. That means these patients have less than 40% ejection fraction. They have worse prognosis, and also this patient ejection fraction less than 40%, beta blockers, RAS inhibitor, MRA do not seem to work in this patient. So what about withdrawal of the drug in this patient? The famous TREAD-HF story looked at this question. There are a patient who is diagnosed with previous DCM. They are fully recovered. They have a normal ejection fraction, normal LV diameter, and normal antipropion level. 25 were randomized to withdraw the drug, and 25 continued. And there was stepwise withdrawal of the drug, beginning with diuretics, MRA, and beta blockers, and finally asymptomatic ARB. And they looked whether there is less of a DCM at 16 weeks and at 6 months. And when you're looking at the baseline characteristics, the time since the initial DCM was about 5 years and 4 years in both groups. Initial LV ejection fractions are around 28 and 25. Interestingly, the time since the LV ejection fraction greater than 50% was 28 months and 20 months, so about 2.5 years and 1.5 years. And ejection fraction at the study was 60, more greater than 60%, and they were well treated. So on the right side, we have a treatment withdrawal group. And they decrease the ejection fraction, increase in heart rate, increase in the LV volume, and increase in BNP level. At 6 months, about 40% do have increase, do experience it relapse DCM with an increased risk of 55%. The last question is that if there's a drug that works in both in HFrEF and PEF, we should not have to question whether we should stop the drug or not. So we know that from the EMPEROR program with the SGLT2 inhibitor, the primary endpoint, which was composed of CV deaths and heart failure hospitalization, could be reduced by 25% in EMPEROR reduced, and as well as in EMPEROR preserved, 21%. And the secondary endpoint was total heart failure hospitalization that could be reduced by 30% in the reduced and 27% in preserved. They're pretty the same. But if you look at here, the rate of the placebo was 25% in preserved and around 50% in the reduced. So we have two different population with different risk for heart failure aggravation. The FDA endorsed the use of sacubitril/valsartan and spironolactone in patients with ejection fraction less than normal. And we know from the PARADIGM-HF study with the ejection fraction less than 40%, compared to enalapril, sacubitril/valsartan could reduce the CV deaths and heart failure hospitalization by 20%. But in patients with preserved EF, defined as greater or equal to 45%, sacubitril/valsartan compared to valsartan could reduce the total hospitalization or CV deaths by 13%. That was not statistically significant. But we know from the other analysis, so-called the expanded composite endpoint analysis, which include urgent heart failure here, the hazard ratio is the same, 0.87 in the original study, 0.86 in the expanded composite endpoint. But because there are more events in both arms, the p-value became significant, suggesting that this drug may work in HFpEF patients as well. If you combine both study paradigm H and paragon together, we can have this cubic spline curve, and the confidence interval crosses one at ejection fraction around 55%, and the impact size became neutral about by ejection fraction at 64%. So this drug may work in patients with below normal ejection fraction. Another interesting analysis, putative plasma analysis. You can compare sacubitril/valsartan with putative placebo, and this drug may work both in HFrEF and HFpEF. In HFpEF, the risk reduction may be 29%. And the same story with the ejection fraction and sacubitril/valsartan effect. And in patient with the normal ejection fraction or the below normal ejection fraction, this drug may work too. This is also same for the other RAS modulators. The same story for the candesartan and MRA. So let me summarize my talk, ladies and gentlemen. We know that heart failure with improved EF is not HFpEF, and the withdrawal of the drugs in half improved EF may deteriorate the LV function. It is unknown whether relaxed DCM will respond to optimal medical therapy. Therefore, continuation of the drug is recommended. I think this is important because some patients may say that, oh, I will restart the drug when I will deteriorate my heart function, but currently there's no data where they will have a second chance. So I am of the opinion we should not gamble with this. We know that some drugs may work across all ejection fraction spectrum. It's especially true for the SGLT2 inhibitor, which in my opinion is not really a neurohormonal modulator. It's rather a cardiometabolic drug. That might be the reason why they work both in HFrEF and HFpEF patient. Thank you very much.